You're listening to the Fertility Docs Uncensored podcast, featuring insight on all things fertility from some of the top-rated doctors around America. Whether you're struggling to conceive or just planning for your future family, we're here to guide you every step of the way.
Hello, everyone. This is Dr. Susan Hudson from Texas Fertility Center. I am here with my friends today, Dr. Carrie Bedient from Fertility Center of Las Vegas and Dr. Abby Eblen from Nashville Fertility Center for another episode of Fertility Docs Uncensored. And we're so excited today. We have Dr. Tex VerMilyea, who is the Vice President of Scientific Advancement through Ovation Fertility with us today. Hey, Tex.
Hello.
Hey.
Happy to be here.
How's everybody doing?
Great. Good.
Well, it's hot. It's hot in Texas.
Oh my goodness. It is so ridiculously hot in Texas. It is 105 degrees.
It's probably
correct.
humid and sticky and icky there too.
Oh, you Las Vegas people.
Yeah.
But it's a dry heat.
Yeah, whatever. It's 110 degrees here, but I guarantee you it feels better than your 105 and the stickiness and the instant bath as soon as you walk out the door.
Yeah. Oh, no.
And your mosquitoes as big as birds.
Yeah. What are mosquitoes like in Nashville, Abby?
They're pretty bad. I think if I walk into a room of 100 people and there's a mosquito there, it would bite me. So they're pretty bad. And we even have like West Nile virus from our mosquitoes and all other kinds of germs that we can get from mosquitoes. So we have lots of mosquitoes, but they're probably not as big as the ones in Texas, I'm betting.
Oh my goodness. I can tell you that the Minnesota mosquitoes, when I was in training, those were the worst. However, the funny thing is, the flies in Minnesota were very weird compared to Texas flies. In Texas, we have these little bitty flies and they're like super fast. So growing up watching The Karate Kid and you saw Mr. Miyagi with his chopsticks catching the fly, like as a kid, I could not, and like I was just always in awe about this. And then I moved to Minnesota where they had these huge flies and like you could actually catch them if you tried.
Did you ever successfully pull off the chopstick maneuver with a fly?
I did not pull off the chopstick maneuver with the fly, but I could now understand how the chopstick maneuver could happen.
I can bet with Texas hand-eye coordination that we were talking about earlier, I bet he could pull off the chopstick maneuver to catch a fly. Have you ever tried that?
I haven't tried it. I use it's called a bug assault, and it's a gun that shoots little salt and
I've seen that.
Gets the flies. Yeah, so much easier to use than chopsticks.
We have an electronic
Tennis racket?
Thing.
Tennis racket. Yep.
It's called the Executioner. It works really well.
We just run around with a bottle of Windex and just spray the flies with Windex, and they go down with that.
Did you watch My Big Fat Greek Wedding one too many times?
Possibly.
That's the first thing came to mind. Yeah.
But it does make me grateful that Tex at least has his little assault gun and doesn't go around with his welding torch trying to get him with the welding torch, because I feel like that would result in a house fire or somebody putting their eye out.
That's correct. That's kept in the garage at all times.
So Tex, I understand that you have a former hobby as a pole vaulter. Can you tell us a little bit about this?
I think he had a scholarship for that, Susan. It wasn't a hobby. He's like really good at it sounds like.
Well, I don't know if it's a hobby. I've known to run with a fiberglass pole and pole vault. Did it in high school for quite a few years, actually in junior high, and kind of worked my way up. And I was able to do some at Cornell during my days.
So he's not just a hobbyist, he's really good.
So when was the last time you actually pole vaulted?
Oh boy, it's been a very long time. I don't think I could get vertical like that, like I was able to back in the days. I think maybe using a broomstick over a stream, probably in the last 20 years. But other than that, no real height.
What's like the highest height you vaulted? I don't really have any realm of kind of knowing what normal is. What's normal?
Yeah.
What you do?
So I believe my highest was about 14 foot. But, now Olympians are, 21, maybe 22 feet. And the technology of the actual pole has obviously evolved. And, from back in the days, it was bamboo, and then it was aluminum. And then they moved to fiberglass, and now I believe they use carbon fiber. So it's all about getting the right bend. And yeah, just the technique, sudden burst of speed, and got to get the pole in the box and go over the crossbar. So yeah, it was good.
That's cool. That's cool. Well, we have our question of the day, which I almost forgot about.
You're surprised, Susan. Oh,
I know. I'm always the person who remembers. And when I'm hosting is the one time I forget. So our question of the day is, even though I have periods consistently every month, could I not be ovulating? Ladies?
It depends. It depends on how far apart your periods are. And usually kind of the rule of thumb I say is if your periods are more than about 34 days apart, you're probably not ovulating consistently. You may ovulate randomly here and there, but you're probably not ovulating consistently. What would you say, Carrie?
I would say even sometimes patients who have regular periods that are 28, 29 days apart, it's still possible to have periods that are non-ovulatory. I actually just had a long conversation with a patient who's 24 years old. She is a type 1 diabetic, and her periods are very regular. Her sugars are very well controlled, which is an important point because blood sugars are often one of the most common causes that throw things off with ovulation. And she's been checking ovulation predictor kits, and the whole reason she came to see me is because they don't turn positive for her. And when we checked a day 21 progesterone level, it was very low, showing that she hadn't ovulated. And so, yes, it is possible to have regular periods, but still not be ovulating regularly.
But that's not a common thing though, right? Would you say?
No, I don't think it's common at all.
Okay.
It's not common, but I think we all see it enough that it is something we are all aware of. And it's one of those things that because you have periods doesn't always mean that you're ovulating, but if you're ovulating and you don't get pregnant, you will have a period pretty consistently.
Yes.
Yeah.
Fair?
Yeah.
Good stuff. Good stuff. Well, kind of moving on to our topic of today, we're going to talk about how is the magic created in the lab? And, how do we get those little embryos to do their thing? So I'm going to hand it over to Tex and let him share what you do every day.
So let's start from the beginning of when we're doing stuff in the IVF lab. So patient's asleep. We've gotten the first sets of eggs out, and they have left our hands, and they have now gone to the embryologist. So the embryologist has the egg in hand, and what happens next?
Right. Yeah. So after an egg retrieval, the embryologists are usually handed a test tube or a tube which has the fluid from the follicle, which has the egg. And so one of the first tasks that the embryologists do is count how many eggs have been taken from the body. And very carefully, we may choose to take off some of the comforting cells that surround the egg, and basically remove those eggs from the follicular fluid and put them in a growth media or a juice that has the right components to be able to nurture those eggs and grow those soon-to-be embryos in the laboratory. And usually while that's happening on the female side, usually the male partner is either collecting a fresh ejaculate or a fresh semen sample, or the andrologist or the people who deal with the sperm in the laboratory scientists, there may be thawing sperm or prepping sperm, so that later on in the day we're able to add the sperm to the eggs.
So my understanding is after sperm are, quote, prepped, they're pretty resilient. So they can kind of just hang out there. Because I know sometimes patients are like, but I know I have to get everything within an hour and that magic time frame. So can you speak a little bit to that?
Yeah, absolutely. So there are some components in the ejaculate, so in the raw semen, that if we're not able to remove that, and hence when the word prepping the sperm and putting, cleaning the sperm in such a way that we're able to provide or identify the most motile, the sperm that are moving the best, as well as the ones that look the best, as well as, getting rid of the ones that possibly are dead. So if we're able to remove all of those, then the sample or the prepped sample, which has the better sperm, can kind of, sit there for a while, and not cause any additional harm. But there's, a whole bunch of, DNA fragmentation and, reactive oxygenated species, all these kind of things that we want to prevent happening. So as soon as we get that ejaculated raw semen, we basically put it through a cleaning process whereby we're able to get the winners of the sperm ready to go for fertilization.
So go ahead, Abby.
I was just going to say, describe the fertilization process, because I try and show patients a picture of kind of, and I think probably, and correct me if I'm wrong, but the majority of patients have intracytoplasmic sperm injection, which is, correct me if I'm wrong, but it's where you take one single sperm and put it inside the egg. Describe that process, because I think as I think about it myself, I don't, we as clinicians don't personally do that. I think that is like a miraculous process. I think that has allowed so many couples to be able to be parents with just a small amount of sperm. So describe that to our listeners and how that works and how effective it is.
And how you pick out which sperm.
Right, absolutely. Yeah. So in the natural occurring process, there's receptors on the eggs and receptors on the sperm, whereby they kind of, think of two magnets coming together. And, as a sperm kind of works its way, through the uterus, up the fallopian tube, the strongest, survival will make it eventually to the egg. And then, there's receptors whereby the sperm binds to the zona pellucida, or the outside shell of the egg, and kind of works its way in, and then basically deposits its DNA, and then the magic happens. Sometimes, though, that mechanism doesn't occur correctly in nature, or we have too little sperm in order for them to make it all the way to the egg in nature. So we can bypass that system by doing intracytoplasmic sperm injection, which is ICSI, and whereby we, under the microscope, after we've prepped the sperm, we use a very small glass needle, hollow needle, to identify which sperm looks the best, which one's got only one head, which one does not have two tails. And this is based on sperm morphology. So we can use this needle to aspirate or pull that sperm up into this very, very fine needle. And you're sitting at a microscope, and you have these extension of our arms, which are these micro manipulation tools. And it's kind of like playing a virtual video game, whereby you've got the egg on one side and you have the sperm on the other, and you use these tools and gradually use this needle to puncture the egg and deposit the sperm in a very, very safe manner and process. And what that basically does is it circumvents that natural sperm-egg interaction process, which may not be there, by just directly putting that sperm into the egg.
So how do you know when you are creating the puncture to get in? How do you know that all of the biologic processes that are needed to be kickstarted during that process are happening? And also, how do you know that you aren't accidentally damaging an important organelle or one of the small cellular structures that's needed when you go in with that needle? Yeah.
So, there's kind of landmarks on the egg that through historical and through thousands and if not millions of ICSIs allow us to position the egg and hold the egg in such a manner whereby when we stick the needle with the sperm into the egg, we can bypass or not disturb any of the important organelles. And one that landmark it's called the polar body. And the polar body is basically a waste basket of chromosomes that the egg kind of pushes out and releases. So if we aim that polar body at a certain part within or a certain place within the ICSI process, we can pretty much get by with not damaging the egg as we inject the needle. And there's also some other technologies where we can use certain light to identify the chromosomal structure within the egg. But we want to reduce any light exposure to the egg because obviously you don't have light on in the uterus or windows in the uterus. So we want to prevent any additional manipulation on that side. But ICSI has been very, very, very successful for many, many years with this simple technique of positioning the egg in the correct spot.
So how many sperm do you need to do ICSI with? Because, I have patients, some of our male patients have a really low sperm count, or sometimes they even have to undergo a testicular aspiration to get sperm. How many sperm do you need for ICSI?
Yeah, well, it's really 1 sperm, 1 egg. So if you got 6 eggs, you need 6 sperm. It really comes down to the quality of the specimen and the sample. Obviously, we want to identify sperm that are modal and they're moving. There's a way that we kind of stun them to keep them from swimming away. And if you happen to Google videos and see all these sperm moving around, we actually use kind of a thick syrup, so to speak, that allows the sperm to slow down so we can actually catch them with the needle. And that way we can, really visualize the sperm correctly and try to pick, based on morphology, what that sperm looks like, pick the best sperm. So it's really a one-to-one, especially with ICSI. We only inject 1 sperm into 1 egg.
So are the boy sperms the ones that move the further away from you and they're hardest to deal with, or is it the girl sperm?
Yeah, it's hard to tell.
Are the boy sperms faster because the Y chromosomes are smaller and have less material than the X chromosomes, so they're lighter?
There's been some theory, that the slower, with the X chromosomes are a bit more sluggier. But usually it's a 50-50 gamble as to which one you can select.
So once you have the egg that's been inseminated, what happens next to it? So what are they doing? Are they just sitting there? And I know we use the term dish a lot, and we all know exactly what that means because we're all, biology nerds who have worked with these kind of dishes a lot. But to an average person, you say dish and you think dinner platter. And then it's a little different from what you see in the lab. But what happens next? So you've got your egg and your sperm that are together.
Yeah. So we culture, we use the word culture, which is kind of, grow. So we grow these embryos in a dish, and maybe think of a dish as a lid to, a pickle jar or something. So that inverted lid has multiple little droplets of culture media, and the culture media is growth juice, and it really has the nutrients that will allow those embryos to grow, and the nutrients mimic what's in the actual uterus, right? So we want to mimic in the laboratory what's going on, in nature, what's going on in the body, and we tend not to disturb these embryos because obviously we're not taking, every time we take the embryos out of this incubator, which is temperature controlled and has the right gas concentration, every time we remove those embryos out and look at them under a microscope, we're disturbing them. So we want to try to minimize that, because obviously we're not nature taking the embryos out of your uterus and looking at them and then putting them back in, right? So
Curiosity killed the cat.
Yeah, exactly. So we want to try to keep it as consistent and as natural as possible. And we will look at the embryos every so few days. Back in the days, we used to look at the embryos every day, because that way we can identify which ones went from 1 cell to 2 cells to 4 cells to 8 cells, and we would track it all down on a piece of paper. But the science and technology have shown that if we're able to leave them alone, we can get to that blastocyst stage a lot better, and overall have better looking embryos.
So Tex, what type of technologies are coming out that kind of helps us with our curiosity and potentially even techniques, but allows those embryos to stay in that consistent incubator environment?
Yeah, so we've got some fantastic technologies that have kind of come to helm, which has been, one of them is called Timelapse. And what Timelapse technology does is that, under each one of these dishes, there's a camera. And of course, these dishes are plastic and they're clear. So the camera takes a photo about every 5 minutes of that growing embryo. And what we can do by not taking the embryos out of the incubator and putting them on a microscope, having a look, and then putting them back in the incubator, these incubators have this camera built in. So by taking the photos every 5 minutes of the embryos, we're able to put all those videos or put all those pictures together and have a time-lapse video of that embryo development. And so we can get a real understanding of how fast those embryos are growing, how slow those embryos are growing, are the embryos growing, which ones are not. And we're able to, really have a hands-off approach to embryo growth and watching these miraculous events.
So a couple of questions. Do most labs do that? Is that a common thing for people to do? And then sort of the second question is, how does the speed of development make a difference for you as an embryologist?
Yeah, so some labs are equipped with this technology. It's not readily available. It is quite expensive technology on the laboratory side. So some are late adopters, some are early adopters. So not all laboratories have this ability. And the question with regards to growth of the embryo, there's a cool word called morphokinetics. And what that means is that by looking at the morphology and the changes of the cells and the number of cells and how the embryos grow, we can get a lot of cool information about the embryo based on morphokinetics. And with time-lapse, we have a video that we can watch these embryos grow. So perhaps the slower growing embryos, maybe they're the girls. Not necessarily, but maybe they're just taking a little bit longer to grow, and sometimes they may not continue to grow accordingly. So we may choose not to transfer, not to freeze those embryos.
Let me just point out that's not a scientific fact that the girls are growers. I was waiting for you to say something. Nobody called him out on that.
That's true. I had a good audience to pull that one. But then you have
he'll be taken out, flogged, and beaten afterwards. Don't worry. We got
That's right. You got that edit button. But then some embryos grow too fast, and they basically they grow so quickly that they kind of get tired and they stop growing. So it's
that
really
is usually the problem with guys. So maybe he's right.
Maybe they get
I was going there
or something.
There you go.
Thank you for that softball. Appreciate that.
But a lot of cool things going on in the lab, and some of these technologies are also using artificial intelligence. Obviously, with AI, the algorithms and the computer vision can pick up things that we can't see with the human eye. So, helping us better identify, what embryos are going to lead to a viable pregnancy, and that's always the biggest task.
So, a lot of labs have gone to day 5 or blastocyst transfers, whether they're fresh or frozen. Can you explain what exactly is a multicell embryo versus a blastocyst, and what are things you like to see and what are things you don't really like to see when you're looking at those embryos?
Yeah, so the multicell embryo, usually up till day 4, you can still kind of count the number of cells in the embryo. So on day 3, you expect the embryos to be anywhere between 8 and 12 cells. On day 4, those cells start merging together into what we call a morula. And at that point, the cell junctions or the outer walls of the cells start to combine and fade, and you kind of just have a clump of this, cellular matrix. And then on day 5, what eventually starts happening is those cells start to what we call differentiate. So some of those cells have genes that are going to cause them to become trophectoderm cells or TE cells. And those trophectoderm cells are the outer cells of the embryo, and that's will eventually become the placenta. And then some of those cells, some of the genes will turn on, and those cells will become the inner cell mass, or the ICM. And those are, the precursor, or the early cells that become the baby proper. So in order to get to have a baby, you're going to need to have both of those cells. You're going to need those trophectoderm cells and then the clump of cells called the inner cell mass. Now, based on morphology, we have identified
and for our listeners, morphology is how it appears.
Correct. How these embryos look. We would like to see a nice clumping of inner cell mass cells and then multiple, universal looking trophectoderm cells. And so at the blastocyst stage, that's what we're after. And they can be, quite expanded. They can be quite small, but, we're only good as to what we know and historically can identify what we think is going to be the best embryo for, to resulting into a pregnancy. And of course, there's also tools with genetic testing that allows us to further verify and potentially, deselect which embryos not to transfer. But we're looking at, what the embryos look like, how many cells they have, and our culture system, meaning how we're able to grow the embryos, have gotten so much better over the last 3 decades that we don't need to transfer the cells or the embryos at the multicell stage, the earlier day 3. We can actually grow these embryos and let the embryos prove to us that they are competent and they're growing correctly, hence the extended culture to that blastocyst stage.
So what do you think about the thought of, if more embryos are alive at the day 3 point, then make it out to day 5, what do you think about the argument of, well, maybe we should transfer more at day 3 because we're putting them back into the quote unquote natural environment of the uterus at day 3. Yep, I saw the little air quotes over there, Susan. And I really restrained myself from doing it myself, mostly because this is a podcast, not a video. But believe me,
I did it for you.
And I appreciate that. So what do you think about the day 3 transfer? Because going back into the uterus is a quote unquote more natural environment versus going out to blastocyst, where that embryo really has proven itself. I mean, do you think that the uterus at day 3 really is a more natural environment? Do you think that there is a potential increase in pregnancy rates? Do you think that blastocyst transfer is better? This is a topic that there's becoming more and more consensus in our world about what most people do, but there's certainly not all consensus, and different docs do different things.
Absolutely.
And patients still ask us. And
they use that exact argument.
Right. Yeah. So being a lab guy, I have so much confidence in my culturing system that if an embryo doesn't make it to the blastocyst stage in my lab, more than likely it will not make a blastocyst in the uterus. Now, if you asked me this 15 years ago, I may have a different story, but that's not the case. We have really dialed in our embryo growth systems, whereby I'm, very confident that, we'll be able to get the blastocyst. And through the evolution of what we've done in IVF, by putting multiple embryos back on day 3, you always have that risk of having multiple pregnancies. And that's really a big no-no nowadays. We want to have, one egg, one embryo, one birth. It's better for the patient. It's better for us. It's better for the baby. So by really pushing those embryos, so to speak, in the culture system, in the laboratory, and identifying which ones are more superior based on their development to that blastocyst stage, I'm confident that, blastocyst transfers are the way to go.
Sort of on a different note, but also a patient question I get a lot is, say if I have a young, healthy patient, she comes in for egg retrieval, we get 15 eggs. What number would you give her? What chances would you give her of having normal embryos at the end of it? And how many would you expect looking into your crystal ball? Because I think people are continually surprised by the inefficiency of human reproduction. They expect that we're going to retrieve more eggs and that they're going to have a lot more embryos at the end of it than they actually do.
And there's really a lot of attrition there, and people don't realize that.
Mm-hmm.
Right. Absolutely.
What's normal?
A setting on the dryer.
Again, I'm looking for that crystal ball. There's so many factors involved in the process. It's hard to give you a direct answer. But what I do tell patients is, it's kind of the funnel effect, right? You start off big and then you kind of move your way down. When a patient has an egg retrieval and has been told that they have 20 eggs, that doesn't mean they're going to have 20, chances at pregnancy. Not only do you have 20 eggs, but then, the number gets smaller by the number of mature eggs. You may only have 15, right? And then if you have 15 mature eggs after your fertilization, you may only have, 10 that fertilize normally. And out of the 10 that fertilize normally, you may only have 5 that make it to the blastocyst stage. Out of the 5 that make it to the blastocyst stage, maybe only 2 to 3 of those are chromosomally normal. So it's hard to put a real number on that. There are some statistics. There are some, in fact, artificial intelligence is now looking at this data to sort of predict the chances and the odds. But A lot of it goes back to patient age and sperm factors, as well as making sure you're going to a good laboratory that can grow these embryos. So yeah, I can't give you a specific number. I wish I could, but it's multivariable.
Yeah, but it's clear to say that if you start out with a bunch, you're not going to have a bunch at the end. You're probably going to have, best case scenario, maybe 2 or 3 genetically normal embryos in a young woman. Would you agree with that?
I would agree with that. Absolutely. Yeah. Yeah. And if you do have a lot more, consider yourself lucky and go get a lottery ticket that day. It could potentially happen.
So Tex, something that you hit on a little bit ago when you were talking about, is the uterus the best place or the lab the best place? And you commented that in your lab nowadays, you feel very confident that if the embryo did not progress to a blastocyst at day 5, that it was not going to result in a baby. And I, as somebody who has used one of your labs for a number of years, and I'm sure Abby and Carrie would agree with me that we have that confidence in our Ovation labs, which is absolutely fantastic. But unfortunately, not all labs are created equal. Okay. I see this when people come to me from, they've done IVF cycles elsewhere and they've had, when I sit there and look at them as a patient and I look at the numbers and, the stimulation, and I'm like, I think we need to do this again because I think the issue is the lab. That's one thing that I know a lot of patients, not necessarily at the beginning of their fertility journey, but people who have gone through IVF cycles elsewhere and they're looking for a second or third opinion. How, as a consumer, coming from the lab side, how would you try, because I can say there's no right answer to this because we talk about this all the time. There's not a great comparison, but how would you advise patients who are looking for a quality lab?
Yeah. Great question. I think a lot of it is kind of word of mouth, but also, ask the questions. Go to the laboratory or ask to speak to, one of the laboratorians, and you can easily ask, what is your blast utilization rate or your usable blast rate? And what that number is it's the number of embryos that grow to the blastocyst stage based on, how many started off that were fertilized normally. And, if that number is, less than 30%, it's probably not a good lab. We try to stay within the 50 to 65% range. But, that's an easy question. And you can ask about the, culture conditions. Do you look at the embryos every day? I would say that's probably not a good thing. We have shown that undisturbed, do not disturb, hang out your do not disturb sign on the incubator. Same thing you would do at a hotel room, leave these embryos alone, let them stay in their controlled environment. And again, looking at statistics that are potentially available, going to SART website or looking at what kind of published data is around for these particular laboratories. But there's a lot of different things, and again, I think you can feel based on how responsive laboratories are and how successful they are just through some open communication and see what kind of answers you may get.
One thing I would advise people listening out there is, if you go to your lab and they won't talk to you, that in itself to me is a red flag, because you need to have embryologists who are open and honest and willing to talk to you. And don't be afraid to ask to talk to the embryologist, because it sometimes feels like the embryologists are the people behind the screen, like the Wizard of Oz. But that's not who they are or should be.
Very true.
I think all of us would agree that our embryologists are largely responsible for the success that we have in IVF. I mean, we take the eggs out and we put the embryos back in, but in between there, the lab is key. I mean, the lab is really responsible for our success, for sure.
Very much so. Without them, we don't go anywhere.
Yeah, and these are, highly specialized individuals who really love what they do. And it's kind of, the idea of being lab rats behind the closed doors and doing this fine, detailed work. Most of us have OCD and want to make sure we get it right. And, we can't mess up, and we don't. But we really have a passion for what it is that we do. And, I've got many, many memorable or memories of meeting a patient at time of retrieval and, seeing their number, seeing their plan of action for fertility treatment and, going in the laboratory, doing what we do and, kind of becomes a bit of a distant memory. And then they show up a few months later with a baby. And, it's really touching, especially on a laboratory scientific side, is the miracles that happen behind the closed door.
It is miraculous.
That's awesome.
Mm-hmm.
Very good. Well, on that note, Tex, thank you so much for joining us. You're amazing to talk to and a wealth of information always. To our audience, thanks for listening and be sure to tune in next week for more. Also, be sure to subscribe and leave us a review in iTunes. Would love to hear from you.
You can also visit us on fertilitydocsuncensored.com to schedule an appointment with any of us. Or if you have a question, we'd love to answer it. All will be answered anonymously, and the more embarrassing, the better.
All right, everyone. We will talk to you soon. See you next week. Bye, y'all.
Bye-bye.
Stay safe. Bye-bye.